So yeah, so we'll talk about pulmonary neoplasms. Really, the big thing to know about this is to know when to refer, because you guys, if you're doing primary care or really anything other than pulmonary, you aren't going to be managing patients in office, or you shouldn't be. And so I'm just going to go over the things you'll need to know for test, and also to know what to do as a primary care provider to get people where they need to go. The biggest thing that you're going to see is single or solitary pulmonary nodules. They're usually less than 3 centimeters. I always tell patients that CAT scans are great because we can see things on CAT scans that we can't see on x-rays, but CAT scans are bad because we can see things on CAT scans that we can't see on x-rays. So we may find a nodule that's 5 millimeters, and now that we know that it's there, we have to document stability for 5 years. So it may have been there for 5 years, but we don't know, and now that we know that it's there, we got to prove that it's not something bad. Most of these pulmonary nodules are going to be found incidentally. Oftentimes they're small enough that you wouldn't even see them on an x-ray. A lot of times where we get them is that either somebody had a cough or something unrelated that ended up getting a CAT scan and they found these nodules, or somebody had some sort of abdominal CT, and on an abdominal CT you'll catch the bases of the lungs. So oftentimes we'll pick up nodules, and once they've been found, they've got to be followed. Most pulmonary nodules are round. They're usually singular by themselves. There's not associated haziness, atelectasis, or adenopathy, or large lymph nodes. Usually, like I said, it's an unexpected finding. You're looking for something else and just happen to find them. The problem with them is that they're high risk for malignancy. And again, if I were to walk in and have a pulmonary nodule, I'm not at a huge risk, but if I'm someone who smoked 2-3 packs a day for 20 years, now I'm at a high risk. Benign nodules are usually infectious granulomas, so something has insulted the lung in the past and it just corners it off and seals it off to keep it away, and you get these little calcified granulomas. I have to look on here because I can't really see it. See, do you guys see the nodule? New game, where's the nodule?
It's on the left.
Right here.
Right there.
Right by the scapula. So again, they can be very subtle. And that's the reason why oftentimes these aren't always picked up. Now, I know you guys have had some radiology, and the systems-based is a weird concept for me. When you're reading a chest x-ray, really the only way you're going to get good at reading chest x-rays is to read a lot of chest x-rays. There's a lot of physicians at the hospital who don't even look at the x-ray, they look at the report. And one thing that's always good to get into a habit of is looking at your own films and then reading the report, and you'll learn kind of how to read and what looks normal, what doesn't look normal by looking at them over and over and over again. They talk about a systematic approach to reading a film. The one that we learned was A, B, C, D, E. So A, you're looking at the airway. So we have the trachea coming down, comes down to the carina, splits to the left, splits to the right. Can't really appreciate the carina very well in this film. I think it's right here. If you can tell, this person's had a CABG because they've got sternal wires across the chest. So A is the airway, B is the borders. So we're looking at the heart borders. This is the left heart border, this is the right heart border. These borders should be crisp. If you can't see the heart border, there's something there, whether it's an infiltrate or an effusion. C is, actually C is cardiac. Bones. Bones. So bones, yeah, I will be honest with you, sometimes I forget the bones. So B, bones, we look at the bones, they all look great. C is the cardiac border, D is the diaphragm. The diaphragm is really the biggest thing, one of the biggest things to look for, because if you don't see a nice crisp diaphragm, then that lets you know that something's going on. Either you have a pleural effusion that's doing that, or you have a pneumonia. If it's a diaphragm that's opacified, it's always a lower lobe. If it's doing the right heart border, it's a middle lobe. Obviously, if it's up here, it's the left lobe. It gets a little bit tricky on the left because of the way the lobes do. But anyway, so here's your nodule right here. Maybe left upper, maybe left lower. We really can't tell without a lateral. That's probably upper. So here's your lateral. I believe this is the nodule that they're seeing is back here. So when you have a pulmonary nodule, the first thing you want to determine what is the chance that this is bad. Increased risk factors for malignancy is anything with an age over 30. Obviously 31 doesn't make you at a huge risk factor versus 29, but there's got to be a cutoff somewhere. Smokers, biggest risk factor, if they've had a malignancy in the past, whether it be a colon or something that may be back and metastasizing, and any lesion greater than 2 centimeters. I had to have a little chuckle. Anything over 2 centimeters isn't a nodule, it's a mass. So somebody said something in a report about a 4.5 centimeter nodule. Yeah, that's not a nodule, that's a mass, that's big. So most of these pulmonary nodules will be less than 2 centimeters. So the first thing you're going to do on anybody that you find a nodule on, whether it be on an x-ray or a CT of the abdomen, is you're going to get a CT of the chest. Even though you've got this CAT scan of the abdomen and you see this lesion perfectly in the lower lobe, you need the entire chest to make sure there's not more of them somewhere else. So you're always going to get a CT of the chest. It's important to get it with contrast. When you get a CT of the chest without contrast, you don't get a very good look at the hilum and the lymph nodes. And the lymph nodes become important because if you have a nodule and enlarged lymph nodes, now you're more worried about a malignancy. The other important thing to do is look at old films. That's not always there for you at your disposal, but if you're in the hospital and somebody comes in and they've got a film from 2 years ago, look, and if that nodule is there, you're pretty confident that it's probably benign and it's been there for a while. The other thing to think of is if this lesion has doubled in size in a very short amount of time, it's probably not cancer. Cancers don't get big that fast. So usually if it's a doubling time less than 30 days, so it gets twice as big in less than 30 days, it's usually infectious and not malignant. Oftentimes malignant take quite a while, so doubling time can even be a year, and that's why we follow them out for 2 years. So again, CT of the chest with contrast. This was actually Nikki's lecture that I doctored quite a bit, so you may have seen this before, and I'll give her credit for it. The one thing about this and all these margins, you would never look at a lesion like this and say, oh, it's smooth, it's probably fine. You're still going to follow it. So the size and shape of the nodule isn't going to change what you do, it's just going to kind of give you a little bit more worry or non-worry. So if it's smooth, well-defined edge, it's likely benign, like a granuloma. If it's got ill-defined margins, that's bad, kind of like moles. If it's spiculated or has a peripheral halo, that's very bad. Calcifications are easier to explain when you've seen them over and over again. They're very white, if that makes sense. So if they're calcified in the middle, they're more likely to be the benign. If they're cavitary, it's kind of like malignant until you know it's not. Cavitary lesions are very bad. So we talk about 3 categories: low probability, intermediate probability, and high probability. These are always great to put things in boxes, but don't always present that little easily. The things you're looking at basically is age and risk factor. If somebody's under 30 and the lesion's been stable for 2 years, then it's probably benign and you don't have to worry about it. If it's somebody who is 60 years old, has a history of has a family history of lung cancer, and smoked for 5 years, that's probably kind of intermediate. If somebody comes in and they've smoked 2 packs a day for 40 years, that's a high risk, and that's somebody you're going to watch very closely. As far as low probability, you can be just all of these nodules you're going to follow for 2 years. Now, one thing before I say that, you are not following these unless you're a pulmonary person. There's no reason for a primary care person to be following a pulmonary nodule. That needs to be done by a pulmonologist. So if you're in a primary care setting, you see a pulmonary nodule, you get a CT, you give them the disc, and you send them you refer them to a pulmonologist. It's also very important that you give them the disc itself, because the pulmonologist doesn't want to go from a report, he wants to look at the film. And when we compare these, we want to compare by looking at them and looking at the old one, not say, well, the report said it was 3 millimeters, and I think this is 3 millimeters. So they want the actual disc. So if you're in primary care and you have somebody you're referring to a pulmonologist and you get a CT scan, make sure the patient has the disc to take with them. So the low probability protocol is that you're going to repeat the CAT scan at 3 years, 6 months, a year, and 2 years. The thing that you can do with when you're just watching is those CTs can now be without contrast. Once you've done the initial and you know you don't have adenopathy, you can follow them with non-contrasted scans. There are new being about a year or so, low radiation CT scans that are pretty much just used for screening such as this. The recommendations actually were for that all smokers should get one of these every year, except that Medicare has refused to pay for them. So we don't get to use them like we want to. And you also find out that insurance tells you what you can and can't do, which is a bit frustrating. But don't get me started on that. So the intermediate protocol, there's a couple of things that you can do. First thing we usually do is get a PET scan. Are you guys familiar with PET scans? So PET scan, you take in a glucose-based contrast. It takes a bit longer than a CT. It's not the quick in and out like a CT scan. It usually takes 15 to 20 minutes for a PET scan. And cells that are very active are going to take up that glucose, that radioactive glucose, and they light up. Infection can also do it. So sometimes when you get You're not gonna just send anybody for a PET scan if you think this is infectious, because it won't necessarily tell you your answer, because infection can also uptake that glucose. But the PET scan is gonna tell you, is the lesion hot? If it turns out that I have a nodule that I see on a CT scan that I'm worried about, and I send them to PET and it doesn't line up, I'm pretty confident that that's not a cancer. The other thing that you can do is you can biopsy that lesion. Now, you can't biopsy something that's as big around as your finger. So you're really talking about something probably 2 centimeters or more even before you'd be able to biopsy it, because they have to be able to see it to get a piece of it. So you can biopsy these lesions. It's easier to biopsy a lesion that's on the outer side of the lung, and I'll show you that on these CT scans. Anytime you're going through the pleura into the lung, the more lung you go into, the higher your risk of pneumothorax. The risk of pneumothorax is about 10% for a fine needle biopsy. And so if you're going to go through and you're going to give somebody a biopsy, it's better to do the peripheral lesions because they're less likely to get a pneumo than if you're trying to go centrally. If you have a central lesion, another way that you can get to it is a bronchoscopy, and pulmonologists are the ones who do this, and they do them as outpatients and they do them as inpatients. They basically take a scope, just like a GI scope for a colonoscopy or an EGD. They numb up the airways, they go in through they give them conscious sedation or Versed, and they're awake, which is rough because they cough like crazy when you're doing them, even though they don't know they're coughing, you do. But they take a camera, they go in, they look in the airways, they can do brushing, so they can brush the airways. If they see something that looks questionable, they can also biopsy from there. So any endobronchial lesion or lesion inside the airway they can get through for a bronchoscopy. The problem is they can also go outside of the airways to get some lesions. So if there's something central that's pretty close to the hilum and not close to a lot of blood vessels or the heart, they can go outside of the airway and actually get a piece of that and biopsy it that way. So bronchoscopy for more centrally located lesions, and a fine needle aspiration for more of the external lesions. If they're high probability, sometimes we'll just refer them to a surgeon to get it out. If I have somebody who's had cancer in the past and has had a right lower lobe lobectomy in the past for cancer, and now they get a lesion in their left upper lobe, they're going straight to a surgeon, because I'm not even dilly-dally about whether or not I think that's cancer. If I'm really worried about it, I'll send it to a surgeon and they'll determine whether or not they're just going to take it out. Or if there's somebody who smoked for 50 years and they've got a lesion that lights up on a PET scan, pretty sure that's probably cancer, so I'm going to refer them on and we're just going to take it out and check it. We do take out benign lesions sometimes, but you know, time is very important when you're talking about a cancer to get it before it metastasizes. And we'll talk about metastasis in these, and when you see how often they've already metastasized before you find them, we want to get them out quickly. So this is another pretty algorithm. So again, we're going to look at CT scan. If it looks benign, we're done. If it looks benign and it's stable for 2 years. Sorry, let me say that differently. So we're going to CT scan for a total of 2 years. If they're stable after 2 years, you're done. If it turns out that you do the CT scan and it gets bigger, even if it's 1 or 2 millimeters, if it gets bigger, now we're more concerned, now we're doing more. If I have a CT scan and it's getting bigger, they're going right to PET scan to see if this is real or not. And if it's getting bigger and it lights up on PET, they're going to a surgeon. So the other thing that you have to think about when you're sending someone to a surgeon is, do they have enough lung function to have this cut out? You know, I might have a COPDer who does not have very much lung function, is on oxygen. He's not going to tolerate me taking out any part of his lung. So a lot of times on patients, before we send them to a surgeon to potentially have a lobe blocked out, we're going to do lung function tests to make sure that they have enough reserve to even tolerate living without part of their lung. And FEV, have you guys done PFTs? I would love to tell you that gets easier, but I look at them all the time, and I'm still, they're challenging. So if you don't get it, don't feel bad. You won't need them. Most of the time, you don't. So if an FEV1 is less than 1 liter, they're not going to tolerate surgery. If someone has an FEV1 of 1.2 liters, and you're now talking about taking out part of their lung, they may not, you don't ever want to take out enough lung that gives them less than 1 liter when they're done, because they won't be able to survive well or have any meaningful quality of life. In patients who have a really central lesion and we end up having to cut off the entire lung and do a pneumonectomy, we have to do perfusion studies to make sure that even though their FEV1 is greater than 2 liters, so half of that seems like it would be enough, oftentimes when you check and see how much blood flow goes to which lung, you realize that they have more blood flow to the lung you're taking out, so they may not tolerate leaving that in, if that makes sense. So again, if you think you're going to have cancer, you're either going to do a thoracoscopy. Sometimes they'll do a mediastinoscopy first. If there's lymph nodes, they'll make a small incision, go in and sample a bunch of lymph nodes, wait for the pathologist. If the pathologist says that they're malignant, they'll just close up and they're done. They don't even do the thoracotomy, because now the cat's out of the bag and it's already metastasized, and there's no reason to have them do a big surgery, because now you're delaying their chemotherapy until they've gotten better from their surgery. So if they do a mediastinoscopy and they check a bunch of these coronal lymph nodes and they're negative, they'll take them to surgery, they'll take out part of their lung, and then they're done. So again, you have a CT scan and either changes or you're worried that it's cancer. Now you do a PET scan. You can think about doing a biopsy or a bronch. And then it's low probability we talked about just scanning them. So this is a 67-year-old person with a history of smoking who has a history of a lingulectomy. So they've already lost half their left lobe, and now they have a nodule. Their nodule is right here. Again, if I saw this, I would want to see a CAT scan. I wouldn't go like, oh, that's a left lymph node. I would get a CAT scan and see what that looked like. So we have a 2.5 centimeter nodule in the left upper lobe. It's almost like I've seen this before. So this person, you get a CT scan. So you get the CT scan, and there's their pretty nodule. So this one is kind of borderline on a patient who's a smoker. If I would follow this up, I would probably pet this person, because this is a decent sized enough nodule, and they have a history of smoking. I would probably pet them first, and if it did not light up, then I would just watch it. But you can follow up in a CT in 3 months, 6 months. The second that thing starts getting bigger, they're gone. They're going to a surgeon. So the diagnosis could either be a primary tumor, it could be a metastatic lesion, or it could just be a granuloma. This person happens to have non-small cell cancer, and we'll talk about that. So now we're talking about lung cancer. Can't say lung cancer, we have to say bronchogenic carcinoma. That way we look really smart. So it's the leading cause of death in women and men for cancer. That's interesting. It's not necessarily the most common cancer, but it's the leading cause of cancer death. Smoking causes more than 80% of lung cancers, so it's pretty avoidable. Anybody in here smoker? I wish I had kept a log in PA school of all the things that smoking affects in your body, because it is amazing. You can check your cervical fluid, sorry boys, and tell if somebody smokes by looking at the secretions on their cervix. I mean, it affects your entire body. It's just amazing. Okay, soapbox. So certain diagnoses are more common with lung cancer, obviously, including pulmonary fibrosis, COPD, and sarcoid. Obviously COPD, since it's associated with cancer. The average age of diagnosis for cancer is 60 years old. This was kind of shocking to me. The combined 5-year survival rate for all cancers is 15%. It's not very good. And when you think about the fact that stage 1 is considered curable with resection, and the 5-year survival rate, including those, is still 15%. That's not good. So, signs and symptoms. Again, not everybody who has a cough has a tumor, but again, know your risk factors. So a new cough or a change in a chronic cough. A lot of times smokers are going to have a chronic cough. They're going to cough every day, but they'll come in and tell you it's either happening more often, or it's a dry hacky, or it's just different. They can be short of breath. They can have bone pain or chest pain. Obviously, if they're having bone pain from lung cancer, it's bad, because it's everywhere. Hemoptysis usually only happens in endobronchial lesions, so lesions that you can actually see in the airway. Peripheral lesions don't often give you hemoptysis. They can have a change in voice or hoarseness. Oftentimes that's because the recurrent laryngeal nerve goes through all of these lymph nodes in the hyla, and so any kind of inflammation or swelling can cause a change in voice. They can obviously have anorexia or weight loss. Unexplained weight loss in a smoker is cancer to prove it otherwise, if you haven't heard that already. They can have atelectasis, pleural effusions, or post-obstructive pneumonia. So you have a lesion inside the airway, but none of those secretions behind it are getting out. So that secretion will get infected. So if you have a smoker that you're treating in pneumonia and they get better, and then it's back, and they get better, and it's back, that's bad. That means there's something else going on. So if you don't treat a recurrent pneumonia in a smoker 6 times before your referral, treat it once, comes back, then you go to a pulmonologist, and then you need to see the chest. The problem with lung cancer is that by the time you have symptoms, the cat is oftentimes out of the bag. For it to be big enough for you to actually have these symptoms, it's too big. So really the only lung cancers that we cure are the ones we find on accident. So again, any abnormal chest x-ray has to be followed with CT of the chest. We'd like for it to be with contrast if their kidneys will tolerate it. If their kidneys don't tolerate it, do it without contrast, or if they have an iodine allergy. Iodine allergies are kind of a big deal. Contrast for most scans is going to be an iodine based. Anytime you have somebody who says I'm allergic to iodine or I'm allergic to contrast, ask them, number one, what's your reaction? Number two, ask them if they've been pre-treated. For a lot of these iodine or contrast allergies, we can do a treatment protocol that includes prednisone, an H2 blocker like a Zantac, and Benadryl. And you give it to them 6 hours before, 4 hours before, and then right before, and oftentimes they'll tolerate the iodine. So if you have somebody who tells you that they have an iodine or a contrast allergy, ask them, have you ever been pre-treated? Because a lot of times they have, and that way you know that you can get it. As far as the very easy, there's more than one way to skin a cat, so there's lots of pre-treatment protocols. In the hospital, if you're doing it, it's real nice because there's a protocol that says pre-treatment, and all you have to say is that, and it does it all for you. So most radiology facilities, if you're doing it as an outpatient, will have their own protocols that they can give you so that you can get your patient the medicines ordered to be able to give them the pre-treatment. As far as lung cancer, you have to have a tissue diagnosis to be able to start any kind of treatment. Even radiation, they want to know what is the cell type before they'll treat it. So you always have to have a piece of that tumor to be able to start any kind of therapy. There's a couple different ways to do that. We've talked a little bit about these. So fine needle aspiration, again, they're better with lesions on the outside. Risk of pneumothorax, I was thinking thoracentesis when I said 10%. The risk of pneumothorax with fine needle aspiration of the lung is 20 to 25%. So you kind of have to think about that when you have your little COPDer who's already on oxygen. Is he going to tolerate a pneumothorax? So that's something that you always have to be careful of. And again, you don't want to go too deep in or you're increasing your risk to drop the lung. The other thing that you can think of in those patients who have lesions that aren't really in a great place is you can get a lymph node. If you know that they have a lymph node that's, sometimes we do PET scans just to find a safer place to biopsy, because lymph nodes are a lot safer to biopsy than in the middle of the lung. Again, you could do a bronchoscopy. You guys would never be determining where to do a biopsy. You would refer them to a pulmonologist who would determine the best way to biopsy. So again, you could do a bronch for a centrally located lesion and they can get a piece that way. In people who are having hemoptysis, you can actually do sputum cytology. They'll cough up a sputum sample, they'll look and see if there's cells in there. The only way that's going to help you is if they have a lesion in their airway, which is not common, but it doesn't hurt to do sputum cytology, but it only works really with people who are having hemoptysis. The other thing that you can do is that if you have somebody who has a lung lesion and they have a pleural effusion, fluid in the pleura or the outside of the lung, a lot of times, if that's on the same side as the lesion, you can kind of be real suspicious that that's a malignant pleural effusions. Some cancers, some lung cancers, when they get to a certain stage, can actually metastasize on the pleura, and they cause a pleural effusion. So for those people, we just recently had an 80-something-year-old man who was not real functional, and he has a big old lung lesion. Well, he's also got a big pleural fluid accumulation, so it's a lot safer to do a little thoracentesis than it is to sedate him and do a bronchoscopy. So for him, we ended up doing a thoracentesis and drained that pleural fluid, and it had cancer cells in it, and we got our diagnosis that way. So there's several ways to get diagnosis. It just kind of depends on where the lesion is. So the different types of lung cancer. There are lots of different types of lung cancer, but 90% of lung cancers are either a non-small cell or a small cell. Non-small cell cancer is squamous cell, adeno, and large cell. I would say adeno is probably the most common of those, and we'll go over each one of those. Small cell is the bad one. It's the one that is the least responsive to treatment. It's the one with the lowest survival rate, and it's the one that's the most aggressive. And it's kind of in a class all by itself when it comes to treatment and staging. So when we're talking about treatment and staging, we divide cancers into non-small cell and small cell. Again, small cell is very, very aggressive. Untreated, you'll survive 6 to 18 weeks. And even with treatment, they tend to last about a year. So the 5-year survival rate for small cell is not good at all. And the reason is small cell is not resectable. Oftentimes it's in the hilum, it's encasing a bronchus, it's encasing the pulmonary artery, and you just can't get it out. So those people only get chemotherapy. And chemotherapy does not cure lung cancer. And we'll talk more about that as well. As far as non-small cell cancer, it tends to be a little bit more friendly. They tend to not be as aggressive. In the early stages, stage 1, sometimes stage 2, you can resect them and they're done. That's considered curative. Once you get to stage 3 and 4, you're no longer talking about a cure with chemotherapy. You're just buying time. So squamous cell carcinoma is a non-small cell that accounts for 25 to 35% of cancers. It's usually more centrally located in the lung. These are oftentimes interbronchial lesions. Those people tend to have metastasis. Again, you have a lesion in the airway, they tend to be very vascular, and so that's where the bleeding comes from. These you can get a diagnosis sometimes with sputum cytology. Again, it's only diagnostic in 20%. So it's not a real high yield, but if you have somebody who's weak and wimpy and you don't know how much they're going to tolerate invasive procedures like biopsies, it's not going to hurt them to do a sputum cytology. It might not work, but if it does, you've saved them the risk of a procedure. Squamous cell cancers tend to spread locally, so they tend to spread to lymph nodes in the area. You can get hyaline-lymphadenopathy or a widened mediastinum, and I have a couple pictures of that. 60% of people with squamous cell cancer have metastatic disease on diagnosis. That's big. That's the reason why the 5-year survival is so low, because oftentimes once they have symptoms for us to look for this, they already have metastasis. Small cell. I'm not sure why I grouped these the way that I did. Small cell is 15 to 20% of the cases of lung cancer. It's always centrally located. You usually have, again, a widening of your mediastinum on the X-ray. A lot of times these are bad. They're like I said, they're encasing the pulmonary artery. They'll close off airway. They're bad. They're non-resectable because they're in such an important place. We can't go in there and start cutting on things around large arteries. The other thing that's kind of interesting about small cell cancer is it's oftentimes they present with perineoplastic syndrome, so they tend to get SIADH or syndrome of inappropriate antidiuretic hormone release. The biggest time that you're going to see this is hyponatremia. And something that I see missed a couple of times in the hospital, hyponatremia in a smoker is cancer until you know it's not. Always look for a CAT scan. If you have a smoker who comes in with a sodium of 130, get a CAT scan of their chest and at least rule it out. Because oftentimes it could be small cell cancer that's causing this hyponatremia, and you won't know it if you don't look for it. Carcinoid tumor. I have seen 1 or 2 carcinoids. The only reason I even put it in here is because it's listed on your objectives. Carcinoid used to be thought of as a benign growth. It's super, super, super slow growing. And only recently have they really realized that it is a malignancy. They can be centrally located or peripherally located, but most oftentimes they're in the middle and they can actually cause interbronchial lesions. You can also get a GI carcinoid. It's more common to get a GI carcinoid than it is to get a lung primary, but you can. They can also give you perineoplastic syndromes. You can get a cushingoid appearance or the humpback. You can also get SIADH. Once you have if you get a biopsy of a carcinoid, you're going to do a PET scan and you're going to stage them just like anything else. They have to be taken out if there's not disease elsewhere. Carcinoids don't respond well to chemotherapy, so they have to be surgically removed. Adenocarcinoma is also a non-small cell. It includes bronchoalveolar cell. This one's interesting because a lot of the patients, the 20% that will have cancer and not be a smoker, oftentimes it's adeno. So this is the one that can happen in non-smokers. Usually adenocarcinoma is more peripherally based. It's not so much in the center, it's more on the outside. And 80% of these have metastatic disease at presentation. Large cell is not as common. They can be central or peripheral. It's not real common, so I didn't go into it very much. As far as staging goes, staging is important because it determines how are we going to treat this. Is this going to be a surgical excision? Are they going to get adjuvant chemotherapy? Or are they going to get chemotherapy alone? How that's done is a TNM. T is based on the size, so a T1 I believe is less than 2 centimeters, and you have T2 and it goes up based on the size. You have N, which is the evidence of metastasis. N1 is local metastasis, meaning if it's in the right upper lobe, you'll have some pretracheal lymphadenopathy. N2 is distant metastasis, maybe you have supraclavicular or something kind of further away. M is distant metastasis, so bone. If you've got lung cancer with mets to the bone or lung cancer with mets to the brain. Again, staging is important because it directs treatment. Stage 1 and 2, stage 1 can be cured with resection alone. So if somebody has a right upper lobe adenocarcinoma and you do a right upper lobe resection, they're done. You don't need chemotherapy and they're considered cured. 2 is a little bit tricky. It kind of depends on if it's local metastasis that they can remove at the time of lobectomy. Oftentimes they'll go ahead and do that, and that's considered curative. Stage 3B and 4A don't benefit from surgery. We won't do any surgery. We won't even resect anybody who's got And the reason is because the cat's out of the bag. And the problem is that when you do a surgery, you've delayed their chemotherapy. They can't get chemo for at least 6 weeks, sometimes even 6 months after surgery because they have to recover. So if you do surgery on somebody who has an advanced stage disease, you limit how soon they can get chemo. So that's an important thing to remember. I oftentimes hear people talk to patients about cancer, and I'm not trying to squash people's hope, but I think that you have to be realistic, and I think that you have to understand that when you have stage 3 or 4 lung cancer, you shouldn't be talking to patients about chemotherapy curing them, because it won't cure them. You're buying them time is all that you're doing for them. So I've known of people who've had stage 4 disease and they were told that chemo was going to cure them, and they see us and they're like, what? I don't know. So prepare your patients and be realistic. I'm a huge stickler for, even though it's not fun to get bad information or bad news, you just have to do it. It's the right thing to do. Small cell is not staged by TNM. It's got kind of its own deal. And the reason is because almost everybody who's diagnosed is considered a metastatic diagnosis. Even if you can't see any anywhere, there's micrometastasis somewhere. So those people, surgery is not an option. Limited disease means that they only have disease in part of their, in one side of their chest, so that's about 30% of people. 70% of people who have non-small cell, their tumor has already progressed to the other pneumothorax. When you're looking at stage, so how do you stage somebody? The first thing you do is a PET scan, and the PET scan looks for mets. It tells you are there lymph nodes elsewhere, is there a spot in the liver, is there a spot in the bones. The problem with PET scans is they don't do well in the brain, so you can't look for brain mets off a PET scan. You have to do an MRI, and the MRI has to be with gadolinium. So if somebody has a pacemaker or some other contraindication, you obviously can't do an MRI. But CTs, even if a CT is normal, that doesn't mean they don't have brain mets. You have to get an MRI. I talked about with surgical resection. There's sometimes they do surgical staging where they go in, they do the mediastinopscopy, make a small incision, they go in and pull out a bunch of different lymph nodes, and if those are negative, then they'll go ahead and resect. If it turns out that they go in there and sample all these lymph nodes and they have positive nodes, then they will likely not do surgery and just close them up and be done. So there's frozen section being done in the OR, and they're actually waiting for those results to come back before they either complete or stop surgery. If surgical resection is appropriate, we generally take the entire lobe. Sometimes they'll do wedge resections where they'll just staple off that little bit. Most of the time we take the entire lobe just to be sure. Stages 1 and 2 are treated with surgical resection. We talked about that. Stage 1 will not have adjuvant or chemotherapy on top of that. Sometimes stage 2 you might. Stage 3A, again, resection is not indicated. They'll oftentimes get chemotherapy and radiation. Again, we're not talking cure. Stage 4 is basically palliative. They'll either have chemotherapy or in the instance of my brother-in-law who has very end-stage COPD, he can't tolerate therapy at all, so he's getting palliative radiation. So just basically keeping them, it helps symptoms, but we're not curing, we're just buying time. As far as small cell, limited disease, they can get chemotherapy or radiation alone. Usually, if they do have remission, it won't last long. The 2-year survival for limited disease is 20%. For people who have brain mets, you can get whole brain radiation. Whole brain radiation tends to help with symptoms, meaning a lot of these people will present with seizures, and so it will help with symptoms, but it does not change, it does not affect survival. So if they have brain mets and it's basically like a palliative radiation to the brain. It doesn't stop the disease, it doesn't even give them a better prognosis, it just pretty much helps their symptoms. As far as extensive therapy, again, chemotherapy, radiation does not help. The mean survival is 6 to 12 months. 2-year survival, 20%. 5-year survival for extensive stage small cells, less than 5%. So small cells bad. Wrong one. So mediastinal mass. Does that mediastinum look a little bit widened? Yeah. Again, it's not super obvious. So if this was a healthy person, that's one thing. If this is a smoker, that's another. If this is somebody who comes in for unexplained fevers, they pretty much need a CAT scan because you can tell that this should not be this full up here. This is your aortic knob, so you expect this, but all of this over here should not be here. Well, it's lung cancer. Wait, is that it? Okay. So here we go. So the left hilum. really this part up here shouldn't be here. This is your aortic knob, so you'll always be able to see this. But this area up here looks a little fuller than it should. Again, lateral too, on the right, this should not be here. Again, it's just a lumpy appearance. So this could be a small cell, it could be lymphoma. Oftentimes we find lymphoma by a widened mediastinum on the x-ray. Now that's not a lung cancer, so we didn't talk about it, but you can find lymphoma from lymphadenopathy, just causing that widened mediastinum. Pancoast tumor. This is a board question. I've never seen a Pancoast tumor, but you'll see it on your boards for sure. So know it for Horner syndrome, which I have in here. So apex of the left lung. It's usually a squamous cell or an adenocarcinoma. You can have rib invasion, where it'll actually eat into the rib. You can get Pancoast syndrome, which is ipsilateral arm pain. Horner syndrome, which is it messes with the brachial plexus. You get ptosis, meiosis, and anhidrosis. Have you guys heard that before? No Horners. You're going to see it on a test. That's about the only place you'll see it. You'll see it on a test and you'll see it on boards. You may see it in practice, but it's not very common. And again, it can spread from the lung to the ribs. It's very invasive. So in case you can't see it, it's the round opacity in the right upper lip. Again, this is someone else's. So lymphoma, again, you can see it on an x-ray. Oftentimes it's a mediastinal mass, and it's from hyaline-lymphadenopathy. Anytime you see a widened mediastinum, you want to get your CT with contrast because you're trying to see those structures of the hilum better, and you're trying to see lymph nodes, and you need contrast for that. So this is a very unusual looking mediastinum. First of all of this shouldn't be up here, and all of this is all kinds of weird. It looks like this person almost doesn't have a heart. That's just a weird looking heart anyway. But this person has Hodgkin's disease. So you can tell this doesn't look totally different from the person who had just regular old lung cancer. Hodgkin's can look like lung cancer. Usually your patient profile is different. If it's a non-smoker, a younger person, Hodgkin's is more in your differential than a lung cancer. Usually young people who don't smoke don't get lung cancer. So metastatic lesions. The lungs act as a filter. You get lots of lymph that goes through the lungs. So you can get, usually it's not just one nodule, usually it's tons of nodules. They can either be teeny tiny and look like BBs, or they can look like popcorn all throughout the lungs. The most common ones to metastasize to the lung is thyroid, colon, renal cell, and breast cancer. Breast cancer is a pretty common lung met. You can also get sarcoma, although I've never seen that before, but it's usually a big mass. You can get a real streaky, almost looks like pulmonary edema, and it's called lymphangitic spread. And often, I see it the most from breast cancer, and you can get it from stomach cancer as well. Once you see lymphangitic spread, it's very bad. It's very advanced. This is metastatic cancer. So you can see we have tons of little nodules here. This almost looks to me more like a lymphangitic spread because it's kind of hazy and cloudy and lacy all over, as opposed to this. You can see we have a nodule here, we have a nodule here, here, over here. I mean, there's just tons of little bitty nodules, but you don't see that same consolidation, hazy, lacy looking appearance. Do you appreciate the difference between that and that? So this looks more like lymphangitic spread, whereas that looks more like just regular old metastasis. So that's a laryngeal cancer with pulmonary metastasis. So the take-home message for this is that if you're in a primary care setting and you have a patient who has an x-ray that has a nodule or is abnormal, first thing you need to do is a CT contrast, CT chest with contrast, if their kidney function allows and if they're not allergic to contrast. All of these people with an abnormal film need to go to a pulmonologist. If it turns out that this is just a regular old run-of-the-mill pulmonary nodule, that's fine. We'll see them in clinic, we'll follow them along, they'll be fine, and we'll move on. So don't ever be afraid to send something to a specialist that you think isn't that big of a deal, or you think, gosh, maybe I should do this. Send them to a pulmonologist. That's what we do. I think that's it. Questions on lung cancer? Yeah.
When you talk about pre-treatment, what did you mean? Is that something you can use in place of iodine, or?
Pre-treatment is where you give them steroids, an H2 blocker, and an antihistamine before treatment. So there's a 3-hour prep and there's a 6-hour prep. For the 6-hour prep, you give them a dose of, I think it's 50 of prednisone, 25 of Benadryl, and I think it's 150 of Zantac. And then 2 hours before, you give them that same dosage again, and then you give them the contrast. And so if their reaction is a rash or hives, oftentimes that will keep that from happening. If their reaction is that they have anaphylaxis, we're not going to challenge that. But if someone says, I got a rash or I felt hot, then you can pre-treat them with the steroids, histamine blocker, and Benadryl. Again, I would never challenge a anaphylaxis or a severe shortness of breath. I would find another way. Anything else? Going once, going twice? Okay, you're done. If anybody has any random pulmonary questions, I'd be happy to help since that's what I do.